नमस्कार दोस्तों। आज हम बात करते हैं मेटाबॉलिक डिजीज़ की। जो जो बेसिक पॉइंट्स हैं जो अपन डिस्कस करने वाले हैं, ये कोई वैसे टीचिंग नहीं है, बस नॉर्मल जनरल डिस्कशन है। अगर आपको अच्छा लगे तो ज़रूर वीडियो देखना, नहीं अच्छा लगे तो भी कोई बात नहीं, कुछ ना कुछ सीख के जाओगे। या फिर जो कुछ अगर आपको लगे कुछ ऐसा तो आप कमेंट्स में बता सकते हैं। जो मेन टॉपिक्स जो मैं डिस्कस करूँगा, ऑस्टियोपोरोसिस, ऑस्टियोमलेशिया, रिकेट्स और पेजेट्स डिजीज़। सो पैथोफिजियोलॉजी, बोन रिमॉडलिंग, मिनरल होम्योस्टेसिस। मेटाबॉलिक बोन डिजीज। सो बोन का जो बेसिक फंक्शन है वो क्या है? एक जो बेसिक फंक्शन है वो है बोन रिमॉडलिंग, दूसरा मिनरल होम्योस्टेसिस। सो बोन रिमॉडलिंग क्या है? इट इज़ द कंटिन्यू प्रोसेस, इट इज़ द लाइफ लॉन्ग प्रोसेस विच इज resorption and the formation of the bone. Resorption is done by osteoclast cell and the formation is done by the osteoblast cells. जो normal turnover है bones का है 120 days for a complete cycle of bone resorption and formation. Around 10% of the adult skeletal is replaced annually by these cells. So the key regulator of these process are parathyroid hormone, vitamin D, calcitonin, and the estrogen hormone. So in the mineral homeostasis, through these hormones there is a mineral homeostasis. So mineral homeostasis, they maintain the serum calcium level and the phosphate level at a suitable range for functioning of the enzymes and the other hormones to regulate in a particular parameter. So in the PTH axis, PTH hormone, parathyroid hormone released in response to low calcium, serum calcium. So its activity will be increased if there is a low calcium. So it increase the osteoclast activity, means bone resorption, renal calcium absorption or renal activation of vitamin D. Vitamin D in return increase the intestinal absorption of calcium and the phosphate. And vitamin D and the phosphate calcium, these are essential for osteoid mineralization. So disruption here is the core of the most metabolic bone diseases. So first we discuss the osteoporosis. Osteoporosis is the senile disease और के जीर्णता की बीमारी है. इसमें क्या होता है? दैट इज ए क्वांटिटेटिव डिफेक्ट. Quantity of the loss of bone mass of the bone is lost. So but the mineralization, other parameters of the bone remodeling and the bone activity will be normal. So there is the imbalance which favors the bone resorption over the formation, lead to microarchitectural deterioration, primary or secondary. It can be primary, it can be secondary. Primary in postmenopausal or senile osteoporosis, secondary because of corticosteroid use, hyperthyroidism, post paralysis, disuse osteoporosis or some other drug. These patients mostly asymptomatic because it is the silent thief until a fragility fractures occurs. So the most common site of fragility fractures are vertebral bodies. It leads to the wedge compression fracture, neck-femur, and the distal and radius, which lead to the Colles or Smith fracture. Diagnosis is based on the DEXA scan is the gold standard, which done by T-score compared the bone mineral density to a healthy young adult. So routine lab investigation, calcium phosphate, alkaline phosphate, and the will be normal. So you won't get any in the blood investigation. In the DEXA scan, the normal value will be equal or more than -1. If there is osteopenia, T-score will be 1 to -2.5. Osteoporosis less than 2.5, or severe osteoporosis if the less than equal to 2 point minus 2.5 with fragility fracture. So Z score compared the BMD to age matched peers is useful for secondary cause in younger patient. So this is the normal bone. This bone is the normal bone. See the architecture, and this is the osteoporotic bone. This is the osteoporotic bone. See the sieve-like structures. There is a trabecules are widened and thin trabecules in the bone. So that is a loss of mass of the bone. In the osteoporosis, the management depend upon the various factors. So first line we use in the osteoporosis management, we give the bisphosphonates, aldronate or zoledronic. Zoledronic acid given IV once a year, and aldronate can be given in 70 mg per week. With the first line, it induces the osteoclast apoptosis, but there is a side effect. Side effect most common esophagitis. So whenever you give the aldronate, you give it with a full glass of water and tell the patient to do not lie for around 1.5 hours after ingestion of the tablet. It can other side effect osteonecrosis of the jaw, atypical femur fracture. These are atypical femur fracture are subtrochanteric fracture. Subtrochanteric fracture. These are horizontal subtrochanteric fractures. Other drugs are rank ligand inhibitors. This one is the denosumab. Denosumab is the monoclonal antibody. It prevents the osteoclast maturation, useful in the renal impairment. SERMs, selective estrogen receptor modulator. These are raloxifene. These agonist in the bone. Estrogen is the agonist in the bone, antagonist in breast. So this is a good for postmenopausal women with the breast carcinoma risk. Anabolic agents, teriparatide. Teriparatide is the PTH analog. Teriparatide is the PTH analog. It stimulates the osteoblast. It reserved for the severe osteoporosis. So maximum use is 2 years because there is a chances of osteosarcoma if we continue to use the teriparatide. So this is all about osteoporosis in the brief, not in more detail, but in the brief. And then comes the osteomalacia and the rickets. Osteomalacia and rickets are same kind of disorder. Osteomalacia kind of adult disorder. This is the rickets is kind of children's defect. So that is a qualitative defect. Quantity is okay, but quality is defective. So these are the soft bones due to impaired osteoid mineralization. That is a defective mineralization. So there is a mineralization core. The core mechanism is failure of bone matrix laid down by the osteoblast to calcify. Osteoid defect results in the thick seams of unmineralized osteoid, soft bone. Rickets occur in children before growth plate closures and affect the physis and the bone. Osteomalacia occurs in adult upper epiphyseal closure, affecting the remodeling bone. Common etiology: vitamin D deficiency, most common. It can be nutritional, it can be lack of sunlight, it can be because of malabsorption. Renal pathology: CKD, decrease 1 alpha hydroxylase, renal tubular acidosis, Fanconi syndrome, and phosphate wasting. Hepatic impaired 25 hydroxylation. Drugs like phenytoin, phenobarbital induce the CYP enzymes, increase the vitamin D catabolism. So these are the common etiologies. Clinical and biochemical profile. In the rickets children, there is a growth retardation, bowing of legs, zenuverum, rachitic rosaries. What are rachitic rosaries? There are prominent costochondral junctions. Frontal bossing, craniotabes, widen wrist and ankles. In osteomalacia adult, these patients have the incidence onset. There is a diffuse dull bone pain, especially in the pelvis, lower back, and legs. There is a proximal muscle weakness due to waddling gait and the increased risk of pseudofractures. So there is a biochemical signature in the these patients. Calcium will be low to normal, phosphate will be low, and the alkaline phosphate will be high because of compensatory osteoblast activity. PTH will be high because of secondary hyperparathyroidism. These patients have secondary hyperparathyroidism. Radiological hallmark. These questions asked in the exams. So there is the metaphyseal changes, cupping, flaring, splaying, widening, and the fraying regularity. There is a metaphysis. This is the metaphysis. This is episphysis and this is physis. So this is the widening of the metaphysis called splaying. There is a fraying irregularity called the fraying, and the cupping is like cup shape structure. It's like cup shapes like structure called the flaring. Loss of zone of provisional calcification. There is a no provisional calcification zone and increased radiolucent physis. Widened growth plate. Growth plate is widened. In osteomalacia, overall osteopenia, losers zone you can find. These are pseudofracture zone, these are pathognomic. Radiolucent band perpendicular to cortex. Cortex to perpendicular, they are radiolucent. Common in femoral neck, pubic rami, ribs, or lateral scapula. Paget's disease. Paget's disease of the bone. It is also called osteitis deformans. It is the hectic, deorganized bone remodeling leads to the Paget's disease. It has a three-phase: lytic osteoclastic activity, aggressive bone resorption by bizarre multinucleated osteoclast cells, then mixed osteoblast and osteoclast. Both activity are there. Disorganized bone formation alongside resorption, then sclerotic osteoblastic, dense but structurally weak chaotic woven bone replaced the lamellar bone. Key feature usually affect the older adults. It can be polystotic, means multiple bone affected, more common than monostotic. Monostotic involve pelvis, skull, spine, femur, tibia. Possible etiology viral, paramyxovirus, or it can be associated genetic mutation, SQST-M1 mutation link. That is a in the histology you will find the mosaic pattern of lamellar bone with prominent cement lines. But clinical feature, these patients were often asymptomatic, incidental finding X-ray and the high alkaline phosphate. There can be bone pain is the most common symptom. Bone deformity, bowing of tibia, femur, enlarged skull, head side, increased complication means deafness, cranial or third entrapment in the skull, high output cardiac failure because of the due to the arteriovascular shunt in the hypervascular bone, or if there is chances of cancer, osteosarcoma, rare but lethal complication in 1% cases. Diagnosis usually isolated, marked elevated alkaline phosphatage. Calcium and phosphate are normal. There is a thickened cortices, coarse trabeculae, skull cotton wool appearance. See cotton wool type appearance in the skull. So thickened cortex are thick. These are cortex. See the cortex. These are thickened. Treatment, we give the bisphosphonate, that is a drug of choice to inhibit the osteoclastic activity. So if you summarize all these four common entities, osteoporosis, calcium will be normal, phosphate normal, alkaline phosphate normal, PTH normal. So key description, the loss of mass, normal mineralization, fragility, fracture. Osteomalacia calcium, there is a low to normal calcium, phosphate low, alkaline phosphate will be high, and the PTH secondary to high, that is defective mineralization. Losers zone in adult, cuffing, fraying, splaying in the children. Paget's disease will have the normal calcium phosphate but very high alkaline phosphate. There is a disorganized remodeling, mosaic histology, or high output cardiac failure. In primary hyperparathyroidism, to differentiate from these, there is a increased calcium, decreased phosphate, alkaline phosphate slightly increased, and the PTM primarily increased. Osteitis fibrosa cystica, also brown tumors, stone bone, and groans. We will discuss the question in the next video about these topic. Thank you.